Good afternoon, ladies and gentlemen. I'm Johnny Vlahos from MD Anderson Cancer Center, and I'm going to be speaking about the challenges we face in the uniform application of the TNM staging system to lung cancer. In this presentation, I want to highlight some of the lesser recognized staging elements that are not often included in the summary articles or online resources about our TNM staging system. These are often found in ancillary documents published by the International Association for the Study of Lung Cancer. And these address areas where the staging is undefined, can be challenging or imprecise. Even if we are aware of all of these special peculiarities of the staging systems, there will be instances that result in inter-observer variability that can affect the concordance of one reader with another when applying the TNM classification system. And here we can use recommendations from the Fleischner Society or other publications that I will highlight in this presentation. Inevitably, there will be areas where we still are unable to reach agreement as to the best staging, and hopefully these will form the basis of future discussions for TNM 9. Now, it's important to recognize that no staging system can account for every eventuality, and if there is a doubt concerning the correct T, N, or M category to which a particular case should be allotted, then we should consider TNM General Rule 4, which states that the lowest stage or category should be chosen. And in simplistic terms, I like to consider this as, when in doubt, give the patient the benefit of the doubt. Let's have a look at some particular scenarios. Here is an example of a lesion that is transgressing the fissure in this right lung. Now, in this instance, is the lesion a T2A involved lesion because of pleural involvement? Is it T3, perhaps, because two pleural layers have been involved, and that's the equivalent, perhaps, to visceral and parietal involvement? Or would some readers perhaps consider this to be T4 disease due to a nodule in another lobe? Well, this is an instance which has been defined. And if we look at the staging handbook in thoracic oncology, it defines that a lesion that invades an adjacent lobe either through an intact or undeveloped fissure is classified as T2A disease, unless there are other size criteria that would apply. So recognize that these types of lesion penetrating through a fissure are T2A disease. Another problem that can arise is the definition of the great vessels that constitute T4 disease. So here are two potential examples. On the left here, a lesion is involving the left superior pulmonary vein and extending into the left atrium. And on the right, in a different example, a patient has involvement of the left pulmonary artery. Are these both T4 disease? And what is the definition of great vessels? Well, these have also been defined, and as you might expect, involve the aorta, the SVC, the IVC, and the main pulmonary arteries, but only the intrapericardial portion of the pulmonary arteries and veins. So in this instance, this is indeed T4 disease, but in this instance, involvement of the extrapericardial left pulmonary artery is only T2A disease. A different scenario that has specific considerations is that of Pancoast tumors. These are tumors that are all, by definition, T3 disease at least, because they have chest wall invasion. In some instances, obvious vertebral body invasion will result in T4 categorization. But in other instances, we have to use multimodality imaging, including perhaps MRI, to define the extent of the tumor and apply the special rules that apply to this region. It's important to recognize that if the C8 or higher nerve roots are involved, the brachial plexus or the subclavian vessels, this categorizes the lesion as T4. Whereas if we only have involvement of the thoracic nerve roots, T1 and T2, then the disease is T3. Another area to consider are lesions which are ground glass in nature, pure ground glass, but larger than 3 centimeters. Now, this is a lesion that was resected and pathologically was only adenocarcinoma in situ. How do we categorize this lesion radiologically? Is it T in situ or is it T1A? Well, this is an entity which is defined not in the Handbook of Surgical Definitions, but rather in an article in the Journal of Thoracic Oncology. These lesions are classified as T1A, even if they are entirely in situ pathology on excision biopsy or resection. And that's to reflect the perceived increased risk these patients have, even though that has not been categorically demonstrated. Similarly, if we have a patient that has minimal soft tissue component, less than 5 millimeters, that we might typically consider as minimally invasive adenocarcinoma, if the ground glass component overall measures more than 3 centimeters, these are also classified as T1A, not T1 minimally invasive. Another consideration applies to mnemonic type tumors. These are tumors which have extensive ground glass or consolidative components, and we know that these can be difficult to measure. How do we classify a lesion such as this, which is predominantly in the lower lobe, but also involving a little bit of the upper lobe here? Well, these have also been similarly defined in the Journal of Thoracic Oncology. If we have extension to an adjacent lobe, then this is T4 disease, whether it's contiguous or discrete. If the disease is confined to one lobe, but we can't accurately measure it, or it's miliary in nature, then that's T3 disease. And if we have disease in both lungs, which is not uncommon, then we have to apply the T stage to the side with the most disease. And as you can imagine, that can lead to variation between different radiologists as to which side they consider the most involved. Another area that leads to inter-observer variability is in trying to measure lesions which are ill-defined or speculated, as in this example. One reader measured this lesion as 1.5 centimeters and a different reader as 2.4 centimeters, incorporating the speculated margins, and that leads to a difference in classification between T1b or T1c disease. Now, which is the correct application of the TNM specification? Well, this is not really clearly defined by TNM. And so here we might rely on other alternative guidelines, such as those from the Fleischner Society, which guide us to measure the core of the nodule, excluding the speculations. This indeed may lead to us having increased consistency between each other, but it's not necessarily accurate to reflect that that definitely implies that we have increased staging accuracy. We don't know in the TNM classification how these lesions were actually measured in the database that was used. Another problem occurs with a lesion that has extensive lobulations or areas of irregular tumor infiltration. How do we measure a lesion like this? We might look at the axial components. We might think to include the longer components, or perhaps look at a sagittal or coronal plane. And in this case, all of the areas here we can see were metabolically active, so they all reflected tumor. Well, the answer here is recommended in the Journal of Thoracic Oncology that we look at the maximum orthogonal planes. In this case, this measurement here rendering a T3 tumor. Now, we might also consider that we could perform a multiplanar reconstruction, but that's generally not recommended, so that we have increased agreement between different readers. If we start to do multiplanar reconstructions, we might increase inter-observer variability. Another instance that can occur is disagreement between radiology and pathology as to the size of a lesion. In this particular example, a cavitary lesion measured 3.3 centimeters, but on pathology, the lesion measured only 1.9 centimeters, the difference between a T1b and a T2a lesion. Which classification should we use for the patient staging? Well, in this area, we have a definitive guidance, and that is that the pathology dictates the stage. And so this is T1b, and that's even though we recognize that on pathological fixation, there may be tumor shrinkage, and that's particularly likely to happen in lesions which have cavitary or cystic components. And indeed, recently we recognize the increased malignant risk of irregular areas of abnormality surrounding small cysts or areas of bullous change in the lung. And these lesions render a particular problem on how to measure them. Indeed, there is no specific guidance on how to measure any of these confirmed malignancies that were pericystic in nature. Do we measure the largest solid component? That might be appropriate in this case. But in this case, which has irregular thickening around a cystic space, that might not accurately measure the involved tumor. And so here is an area where we inevitably will have some variability in the way that we measure these lesions, and there is no formal guidance. In my practice, I would likely measure the solid component in this lesion, but likely the entire lesion in this lesion. Another area that leads to considerable variability in measurement is in the entities of subsolid lesions, those that have both ground glass and solid components. And this is important because in subsolid lesions, only the solid component should be measured for TNM classification. But if we can't agree if a lesion is subsolid, then we don't know whether we should be measuring the entire lesion or just the solid component. And different readers may classify these lesions as different entities. One may think they're solid, someone may think they're subsolid. Indeed, we know that we don't have perfect agreement in whether lesions are subsolid, and that leads to variability in their measurement. Again, there is some guidance that can assist us in this region. In general, we should only consider lesions to be subsolid if more than 10% of the lesion is ground glass in nature. And to make that assessment, we should be using 1 millimeter reconstructions and looking at lung reconstructions and lung windows. In those cases which are subsolid, we just measure the largest solid component. Even in large lesions, though, we can have significant variability in the measurement that different readers may have. This is some data from a study that we've conducted, and we can see that 4 different readers selected different slices and different thicknesses to measure this lesion, and there was a range between 57 millimeters and 72 millimeters with a change in staging for those patients. And we know that as the number of classifications that we have for size has increased in TNM 8, we see that that leads to a reduced concordance of multiple readers, or 3 readers even, compared to TNM 7, which had broader and less ranges for T-size descriptors. And so this is something to consider when we're thinking about future iterations of the TNM classification system. Another issue that we have is morphological criteria. In this particular case, we see the classification pathologically of visceral pleural invasion, and that correlates very nicely with outcomes in patients and the differences in survival these patients have. But radiologically, it can be difficult to determine if a patient has visceral pleural involvement. And we know that there is increased likelihood of visceral involvement with larger, solid lesions that have broader contact. And in those patients that have pleural tags that are thickened at the pleural edge, we might have some increased risk of pleural invasion. But that's not an absolute rule. In this set of examples that I've provided here, the smaller lesions have visceral pleural invasion confirmed, and these larger lesions with broader contact and pleural tags did not actually have visceral pleural invasion. Different radiologists will have different thresholds for suggesting visceral pleural involvement, and that will lead to inter-observer variability between us. How we classify nodal involvement outside the thorax also is variable. Now, some of these nodal classifications have changed in recent iterations of the TNM classification. So in TNM 8, if we have a single non-regional lymph node, such as an abdominal lymph node, then we can classify this as M1b disease, even though metastatic disease is typically non-nodal disease. In this instance, we have a special rule in TNM 8 that a single distant non-regional lymph node can be classified as M1b disease. But of course, we have other situations such as intrathoracic non-regional lymph nodes, in this particular case, an internal mammary lymph node, or multiple non-regional lymph nodes that still defy classification in our current TNM staging system. Now, sometimes even if we know the rules, we don't know how to apply them because we don't know where the primary is. Here's an example of a patient who has 2 areas of abnormality, and it's difficult to determine which to apply the T descriptor to and which the N descriptor. And this leads to some subjective variation. We can assume, for example, that perhaps this prevascular lesion is the primary, and there is mediastinal invasion, and that this is a node, and that results in a T4N1 classification. Others may consider that both of these lesions are nodal, and there is an unknown primary, so TXN2 disease. And others still may consider the left hilar lesion as a primary, with invasion of the hilar fat, which is a T2A feature, and that this is an ipsilateral node, so T2AN2 disease. How do we use our variability to classify this particular case? Well, here it's important again to remember that TNM General Rule 4 and apply the lowest classification. Now, finally, lymphangitis carcinomatosa is perennially excluded from the TNM classification system. There are many different ways that this can be considered: T3, T4, M1A disease. In practice, this doesn't really generally result in problems because usually there is other concurrent pleural disease, which is M1A disease or other advanced disease features. And this feature will be recorded for TNM 9, so we will have a formalized classification of the significance of it. So in conclusion, I wanted to highlight some of the subtleties of the TNM 8 classification, which aids us in accurate staging. There'll still be some undefined scenarios that persist, and these, remember that we can use TNM General Rule 4 or have a tumor board discussion. And hopefully future iterations of TNM classification system will consider the applicability and inter-observer variability. Thank you all for your attention for this presentation, and also for the Essentials of Radiology course, MSES 32. Thank you very much for your participation.